Hi, everybody. This is Dr. Hall. So, if you don't want to get pregnant and go through childbirth or have your partner go through it, what are your options? So, we're going to start talking about contraception or birth control in the next two sections of the lecture. So contraception, conception is getting pregnant. Contra means against, right? So this is against getting pregnant, contra to conception. So contraception is just another way of saying birth control or the prevention of a pregnancy. So first we're going to talk about contraceptive methods that use hormones, and then in part C of the lecture we'll talk about some non-hormonal options. So we're going to start with the hormonal methods because overall they tend to be much more effective than the non-hormonal methods. They're also, from a physiological standpoint, a little more interesting. So there are two different flavors basically of hormonal contraception. There are those that contain both estrogen and a progestin, which is a synthetic progesterone, which we call combined hormonal contraception, or CHC, and then there are progesterone-only methods. So the combined methods that contain both an estrogen plus a progestin have two main mechanisms of action, or ways in which they work to prevent pregnancy. The first is that the progesterone component actually ends up changing the cervical mucus. So normally at ovulation, the cervical mucus changes and forms these channels in it that direct the sperm and say, swim this way, and it helps them to go in the right direction, and it makes it easier for them to pass through the cervix. If you are taking a progestin, however, the mucus changes and the molecules inside the mucus get oriented every which way, and it's like barbed wire. The sperm can't get through at all. And so what's really interesting is this thickening of the cervical mucus prevents a physical barrier, and the sperm cannot get through the cervix up into the uterus and out to the fallopian tube to meet the egg. So that's pretty darn cool. The other thing that can happen, depending on the CHC, if they're really low dose, this usually doesn't happen, but in some people, much of the time, that exogenous, meaning coming from outside, estrogen and progestin raises your hormone levels, and your hypothalamus goes, oh, there's plenty of estrogen and progesterone around here. I don't need to make any GnRH, and so then the pituitary doesn't make LH and FSH, and then the ovaries take a nap. Right? So this negative feedback by taking a hormone can cause your ovaries to just, go on break for a while, which is great because then they're not developing and releasing an oocyte, right? Then we're suppressing ovulation via this negative feedback. So I found this on the internet. I loved it, right? So on the left, it's not like the way combined hormonal contraceptive works is by making the uterus this hostile, massacring place for sperm, right? The primary mechanism of action is this thickening of the cervical mucus, right? They're like, WTF, let us in, right? The sperm cannot get in at all. It may also cause inhibition of ovulation, right? So here's the oocyte not being matured and released because of that negative feedback. The little sperm in the middle there's some evidence that maybe it changes how the cilia do their thing, might make it harder for sperm to swim in the right direction. That's less clear. But certainly the primary mechanism of action is that thickening of the cervical mucus, and there may also be an element of negative feedback causing inhibition or suppression of ovulation. So there are three basic ways to get CHCs into your body. So it's always the same hormones. It's always an estrogen and a progestin, maybe slightly different doses or slightly different types of those hormones. But there's three different ways to get those into your body. So one is if you take them orally, so you put them in your mouth and you swallow them, that's the pill. And some pills come in these little round packs, and some come in these calendar packs, and you punch out a pill every day, and they have the days of the week to help you keep track. And classically, there are 3 weeks during which you are taking pills that contain estrogen and progestin. So these 3 weeks here. And then during the 4th week, you see there's a different color pill. During the 4th week, it's usually a placebo pill, which just means it's an inactive pill. There's no actual hormones at all in those pills. What happens then is you're not getting that exogenous progesterone. You probably haven't ovulated. You don't have a corpus luteum. You're not making your own progesterone. So progesterone levels were relatively high, and now they fall during that placebo week. That decrease in progesterone levels causes breakdown and shedding of the endometrium. It causes what seems like a period, right? So it's different than a natural period. It's not medically necessary to have this progesterone withdrawal bleed if you're on birth control, but it's kind of become the conventional way that people often take them. So the pills are one way to get these hormones into your body. The other is to use a patch, right? So transdermal, meaning across the skin. So what's interesting about estrogen and progesterone as hormones is that they are actually lipid-soluble molecules, and so they can be absorbed quite well through the skin. And the way the patch works is you stick a patch on your skin in one of the locations demonstrated, leave it on for a week, take it off, put a new one on, leave it on for a week, take it off, do a third one, and then the fourth week is patch-free, hormone levels fall, and bleeding will occur. So the patch works really well for people who don't want to have to remember to take a pill every single day, and we know that lots of people have trouble remembering to take a pill every single day. So this can be a nice option. Sometimes it can cause skin irritation, and as you notice from the images, it's this strange pink color that is not really anybody's skin color. So if you need something that's discreet and not visible to a partner, then that wouldn't fit the bill for that. So there's a third way to get these hormones into your body, and that is the ring. So the vaginal ring is this flexible plastic ring. You can see it here, and you squeeze it and to squish it and then insert it in the vagina and let go, and it'll just stay in place there, and you leave it there for 3 weeks. And this ring is impregnated with the estrogen and the progestin, and it gradually releases it. It's absorbed through the vaginal tissues into the bloodstream. So it's just another way of getting the hormones into your body. Pretty cool. During the 4th week, you can take the ring out and hormone levels fall. You have a withdrawal bleed or a quote period. Now, some people ask me, does the ring cause discomfort during sex? Interestingly, they've asked male partners of people who are using the ring whether they could feel the ring during intercourse, and about 75% of them said they actually couldn't feel it at all. The other men said they could, but they didn't mind it. So the partners don't seem to mind. Sometimes the female-bodied person has a little bit of discomfort with the ring with intercourse, and if that's the case, you can remove it for intercourse and then just rinse it off in the sink and put it back in place. That's totally fine. The key there is to not forget to put it back in, right? You need those hormones being absorbed into your bloodstream, so you're only allowed up to 3 ring-free hours per day, and they can't be consecutive. So if you do take it out, make sure to not forget to put it back in. So the ring can be a great method as well for people that find it difficult to remember to take a pill every single day. It's a great choice. One of the things that's neat with CHCs or combined hormonal contraceptives is that you don't actually need to have a withdrawal bleed. You don't need to do 3 weeks of active pills and 1 week of placebo and have a period. This period is not the same period that you would be having if you weren't on birth control. It's due to entirely different forces. And so I think it's really important to talk about the fact that if somebody isn't on birth control and they're not having regular periods, then that means something is wrong. Something in their physiology is not operating correctly and normally and healthfully. So if somebody isn't on birth control and they aren't having regular periods, something is wrong. And so you need to get that figured out, right? If you are on birth control, then we know, and you're not taking placebo weeks, if you just keep taking the active pills so you never have a decrease in hormones and you don't have a period, we know what's causing that. We're causing that, and that's fine. The uterus has no need to clean itself out or anything like that with a monthly period. The uterus is normally sterile. There are normally no bacteria or anything like that up inside the uterus. So extended cycling can be really helpful, especially for people who have really heavy or crampy periods or who get a lot of mood symptoms with their periods, you can just stay on your active pills and not have periods, right? So that can work really well and is totally medically safe to do. One caveat with this is you can't do this with the patch. The patch has a slightly higher hormone level and we're not sure that it's safe. It is absolutely safe to do this with pills and the ring, and in fact some pills are marketed this way. This is a pill called Seasonal and it comes with 3 months worth of active pills and then 1 week of placebo pills at the end, hence the name Seasonal. You have a period once per season, right? Once every 3 months. How poetic. All right, so the nice thing about combined hormonal contraceptives is that they are very effective. So 99.7% effective at preventing pregnancy if taken perfectly. So here's our perfect use failure rate. So 0.3% of women using CHCs over the course of a year will get pregnant if they are using it perfectly. So this means you're taking your pill every day at approximately the same time. You never forget. You never are late starting a new pack, right? Typical use is a different story, right? So this is what happens in the real world. And so we see about 8% of people who are using CHCs will get pregnant in a calendar year, because it is hard to remember to take a pill every day. And we know in studies where women knew they were being studied to see how many pills they forgot per month, they still missed 4 to 5 pills per month. So typical use effectiveness is a little bit lower. So I always say to people when they're thinking about what birth control method to use, I say to them, well, are you going to be a perfect user or a typical user? And some people are perfect users and they do great, but if you're going to be a typical user, you might want to think about a method that's a little bit more effective. So the other thing about CHCs is that there are side effects, medical risks, and some significant benefits that go along with them. So I'm going to take a moment to talk to you about those. So side effects are things that are kind of annoying. So in the beginning, when first starting a CHC method, it's common to have some irregular bleeding, nausea, mood changes, or even some breast tenderness. These usually go away in the first weeks to months. So if they do crop up when somebody starts this method, unless they're severe, we're going to ask them to keep taking the pills, keep using the ring, keep using the patch, because it usually goes away as your body becomes accustomed to the birth control. Now, in some folks, they can get bad headaches or mood changes that just don't get better, and in that case, we'll pick a different method for them. But if it's mild and you can bear with it for a while, we ask you to just wait and see, because usually it will go away. There are a few medical risks, largely due to the estrogen component in CHCs. So there is a low risk of getting a blood clot or a deep vein thrombosis, which is about 1 in 2 to 3,000. As you might remember, sometimes one of those blood clots can break off from a leg vein, travel up through the inferior vena cava, right atrium, right ventricle, pulmonary trunk, pulmonary arteries, and then go out and get stuck in one of the pulmonary arterioles in the lung. And that is called a pulmonary embolus and can be life-threatening. The risk of death due to birth control is about 1 in 50,000. So it does sometimes happen, but it's very rare. To put that in context, the risk of dying as a result of pregnancy and childbirth is 1 in 5,000. So 10 times higher risk of dying as a result of pregnancy and childbirth than of dying as a result of birth control. There is also a low risk of heart attack or stroke, less than 1 in 10,000. And so because of these risks, if you have certain medical conditions, birth control that contains estrogen might be contraindicated for you, meaning that it's not medically safe for you to use it. People, for example, who have migraine headaches with an aura or high blood pressure or a history of blood clots, those are folks in whom it would not be safe to use a CHC. For most people, however, it's very safe to use CHCs, and there's some significant benefits aside from the not getting pregnant one, which is a pretty big one. They include things like decreasing your lifetime risk of ovarian cancer or uterine cancer by 50%. So people who use CHCs for 5 years or longer cut their rate of ovarian and uterine cancer in half. They also can significantly decrease menstrual cramping and menstrual bleeding. So with people with really severe menstrual cramps or really heavy menstrual bleeding that's causing anemia, this can just be a life-saving, wonderful treatment. They also decrease acne and can decrease PMS symptoms. So CHCs can be helpful in lots of ways. So it's always a risk-benefit calculation depending on your particular scenario. So what if you are one of the folks who has a medical contraindication to estrogen, or what if you just want to use a method that's a little bit different than what we've talked about? So we do have methods of birth control that are progesterone only or progestin only. And so these are safe for people with medical contraindications to estrogen, so people with migraine headache with aura, people with hypertension, blood clots, or certain immune diseases. And so you have to wonder then, well, okay, if we can give you birth control without estrogen, what was the estrogen doing there anyway? So the main role of estrogen is to control and regulate uterine bleeding. That's the reason why it was added to birth control in the first place, when birth control was first invented back in the 50s and 60s, right? Estrogen may contribute somewhat to the negative feedback on the hypothalamus, but it's the main purpose, the main reason why we put it in there is to help control and regulate bleeding. So what that means is, if you're on a form of birth control that has progesterone only and no estrogen, it is common to have irregular, unpredictable, or absent bleeding entirely. So it's one of the things to keep in mind. So the first method historically for progestin-only methods was a progestin-only pill, often called the mini pill or POPs. Now, this pill was invented for people who were having side effects from CHCs, and so not only is it progestin only, but it actually has even a lower dose than many or most of CHC pills. So it thickens the cervical mucus, but it doesn't do anything to inhibit ovulation. So this is really great because it has a low likelihood of any side effects. It's very safe, but it also means with this particular method, you have to take it at the same time every single day. You cannot miss it and you cannot be late. So this one is pretty exacting. Some people will continue to have their regular periods, some people will stop having periods, and some people will get irregular bleeding on mini pills. It runs the gamut. There's the Depo-Provera shot, is kind of, if mini pills are the low dose progestin method, this is kind of the high dose progestin method. It's an injection or a shot given every 3 months, which is super convenient because you don't need to remember to do anything every day or week or month. It's highly effective because it's a high enough dose that it not only thickens the cervical mucus, but it does absolutely inhibit ovulation. You definitely get negative feedback on the hypothalamus from Depo-Provera, and it shuts down the ovaries. So because it's a higher dose, there is a slightly higher risk of side effects, things like weight gain, headaches, and mood symptoms. But again, that only happens to a significant extent in about 10% of people. So about 80 to 90% of Depo-Provera users are very happy with this method. Now, one of the things that does happen with Depo-Provera, which is interesting, is because of the pronounced significant negative feedback on the hypothalamus, the ovaries do shut down completely. So there is no estrogen circulating throughout the body because we've got that negative feedback, and the birth control itself doesn't have any estrogen in it. And what happens is you get some loss of bone density if you've been on this for several years, because it turns out that sex hormones, estrogen or testosterone, one or the other, is really important for maintaining normal bone density. So if people are on Depo-Provera for several years, we have to check their bone density and make sure it's okay. The final progesterone only method is the implant. And this is a small, flexible plastic rod that we just slip underneath the skin in the upper arm. So it's actually in between her two fingers here. She's kind of pressing down on the skin so you can kind of see that outline of the rod there. We do this in the office with local anesthesia, right? Lidocaine, that prevents those sodium channels from opening so that the axon can't depolarize. You can't get an action potential. Does that sound familiar? I hope you remember that. And so it just takes about 10 minutes to place it in the office, and this releases a small dose of progestin into the body. And this happens to be the most effective contraceptive we have available. Efficacy is 99.95%. For some reason, even though it's a relatively low dose, it does inhibit ovulation as well as thicken cervical mucus, but it doesn't impair estrogen production, so there's no problems with bone density. So it's pretty awesome. It lasts for 3 years, and it's what I like to call a get it and forget it method. So you come into the office, you get this place, and then you don't need to remember anything, not even to come in and get a shot every 3 months. It's good for 3 years, and it's really, really effective. So of course there always has to be a downside, and the downside is that in up to about half of women it can cause some irregular and unpredictable bleeding. Sometimes it's just really mild and not bothersome, but sometimes it can be somewhat heavy and bothersome to people. There's no way to predict who that's going to happen to, and some people stop having their periods entirely and they're very happy, but the people who have frequent irregular bleeding often are not happy. But this is a great method for those folks in whom it works well. So those are our 3 progesterone-only methods: the mini pills, the Depo-Provera shot, and the implant. And so our final type of hormonal contraception we're going to talk about is IUDs. Now, not all IUDs have hormones in them, however, but I'm going to talk about them as a group. So IUD stands for intrauterine device, and they're these T-shaped pieces of plastic that in the office we insert up through the cervix with a little straw-like thing, and we place inside the uterus. And the way these work is that just like CHCs or progesterone-only methods, they thicken the cervical mucus and prevent sperm from entering, so therefore no fertilization can occur. In the past, it was believed that IUDs worked by somehow mimicking a pregnancy or irritating the endometrium and therefore preventing a fertilized egg or zygote from being able to implant in the endometrium. That's since been proven false now that we have really high sensitivity HCG assays and other ways to see exactly what's going on inside. We've been able to document really quite clearly that they prevent sperm from being able to get to the egg at all. So whereas sometimes people used to worry that these were kind of like an abortion by preventing implantation, we now know with a lot of confidence that they actually prevent fertilization itself. So they're also a get it and forget it method, like the implant, so really long acting, rapidly reversible whenever you want it out. And there's kind of 2 different flavors in the United States. So the first one is hormonal ones. They contain a progestin, so safe for people with medical contraindications to estrogen. Depending on the type, they last anywhere from 3 to 7 years. They're highly effective, and the nice thing about the progestin ones is that they decrease menstrual bleeding, oftentimes significantly. So more than 1/3 of women will stop having periods altogether with lots of types of these hormonal IUDs, which can be really great for people who've had heavy or crampy periods. In fact, the number of hysterectomies or surgeries to remove the uterus because of heavy menstrual bleeding, which is like a thing. It used to be a really, really common thing because women would get so anemic from this problem, has dropped precipitously since these IUDs have become available. And they've been on the market for decades now, and they're very safe. The other type of IUD we have is the copper IUD. And copper will thicken the cervical mucus. It also acts as a spermicide. And so I think you can see on this one here, there's copper wire wound around the stem of that T. And I don't know who figured it out, but copper works really well. It lasts for 10 years or longer. It's also highly effective. It's also non-hormonal. So if you're someone who is really sensitive to hormones in terms of your mood or other things, this can be a good option. The one disadvantage is that it can make periods heavier and longer by up to 50%. So if you were someone who normally had a period that was light and lasted 2 to 3 days, and now you get one that's kind of medium and lasts 4 to 5 days, that's not so bad. But if you're someone who started with a period that was heavy and lasted 7 to 8 days, and now it's really heavy and lasts 10 to 12 days, that can be a problem. So it's often not a great choice for people who already have heavy or painful periods, but other than that, it can be a great choice. So if we look at effectiveness or efficacy of these different methods, what we can see is at the top of the list, right, is the implant, currently marketed under the name Nexplanon. So typical use and perfect use are the same because there's no user error involved, right? It's a get it and forget it method. This is the most effective contraceptive available, more effective even than getting your tubes tied. That's how good it is, right? Second in line are the other get it and forget it method, the IUDs. Again, no difference between perfect use and typical use, no user error. Good for 3 to 7 years, depending on the type. Next up, we have the Depo-Provera shots, which perfect use, highly effective, right? But oftentimes people forget to come in for their shot, or they're a little bit late coming in for their shot. So a little bit of a decrease in efficacy there. Our CHC methods, again, remember we talked about this before. Typical use, people tend to forget their pills or their ring or their patch, so effectiveness is a bit lower compared with perfect use. And then I'm introducing for the first time condoms down here. And so what I want you to notice is that condoms overall, 2% failure rate in a year, that's not bad. It's a lot lower than these other methods, however, and a 2% risk of pregnancy may be much more than you or your partner are willing to accept. But if they're used perfectly, they're not bad at all, and they're much better than nothing. So in the next part of this lecture, we'll talk about condoms. In summary, right, we talked about hormonal contraception in this section. So progesteron's job is to thicken cervical mucus to keep the sperm from being able to swim up through it and into the uterus. Therefore, they can't get to the egg and fertilization can't occur. Estrogen helps to control uterine bleeding, and so that's why it has historically been included in many types of birth control. So CHCs have both types of hormones. You can take them via pills, a patch on your skin, or a vaginal ring. Classically, 3 weeks of hormone, 1 week of placebo, during which you have that drop in progesterone levels causing a withdrawal bleed, but you don't need to do that. If you're using pills or the ring, you can do extended cycling and skip periods. There are some risks such as blood clots and stroke, which are infrequent but can happen, but there's also significant benefits like decreased uterine and ovarian cancer risk, treatment of menstrual disorders, and acne, among others. The progesterone-only methods can all have irregular or absent bleeding. Some people are very happy to say goodbye to their periods. Other people, it makes them uncomfortable. And so there are the progestin-only pills or the mini pills that you have to be super good at taking at the same time every day. The Depo-Provera shot every 3 months. The implant in the arm, which lasts for 3 years. It's a get it and forget it method and the most effective contraceptive available today. IUDs are also get it and forget it, highly effective because there's no user error. The hormonal ones contain a progestin, which will cause decreased uterine bleeding, which can be a very nice side effect. The copper one has no hormone, just copper, which can increase menstrual bleeding, and so for some people that's not a great choice. So that's our summary of hormonal contraception. We'll talk about condoms next.